Good morning, everyone. It's a pleasure to have you all in the second day of the Stroke Summer School 2021. We have some great talks and presentations lined up, and we have star presenters, both our faculty and students. Without losing much time, I shall now invite my colleagues, Dr. Ayush and Dr. Suhas, to take over the proceedings. Have a great day, all of you. Thank you very much.
Thank you, sir. We'll begin the first session. The first session will be on acute stroke management, how we do it. I invite the moderators, Dr. Subhash Kaul sir and Dr. Vijay Sharma. Subhash Kaul sir has been a faculty at Nizams in Hyderabad for more than 27 years, and he was the former professor and head of the Department of Neurology in NIMS Hyderabad. He's currently a senior consultant neurologist in KIMS Sikandrabad. He has more than 120 publications, national and international, to his credit. He's the principal co-investigator of several national projects. He's the past president of Neuroscientists Association. We welcome you, sir, on behalf of Indian Stroke Association Stroke Summer School 2021. I also invite Dr. Vijay Sharma. He's the Senior Consultant, Division of Neurology in the Department of Medicine from National University of Singapore. Sir, we thank you for taking time for being chairing this session. I hand over the dais to the moderators to continue this talk.
Good morning, friends. First of all, I thank Dr. Padma, Dr. Rohit, and all the organizers for arranging this wonderful summer school and inviting us. I welcome my dear friend Vijay Sharma from Singapore, who is my co-chairperson today. And we'll start with the program, and it's my pleasure to introduce the first speaker, Dr. Dheeraj Khurana, whom everybody knows, and I'm sure all of you know. In fact, Dheeraj Khurana has been associated with thrombolysis right from its inception in India. All of us have been, and he really is a real stroke physician, always in a hurry, impatient to thrombolize the patient. It will be a pleasure to hear him. At present, he is professor in charge stroke program in PGI Chandigarh, and he has published on stroke systems of care, hub and stroke models, telehealth, neurosonology, neurorehabilitation. So over to you, Dr. Dheeraj Khurana, please. He'll be talking to us on step-by-step guide. How do I thrombolize a patient with acute ischemic stroke? So it's kind of personalized. How do you thrombolize? And from there, we can later on ask him questions if there's time. Dheeraj, please.
Thank you, Dr. Kaul. Thank you for the kind introduction. And first of all, I would like to thank Dr. Padma and Rohit for inviting me to this excellent, amazing program. Although virtual, but I'm sure everyone will have a great time in the summer school. So I don't do things out of the world. It's like the whole world does it, but I would try to simplify things and put them in a perspective that makes it more practical, safer. The most important thing is we need to be safe, and we need to keep our patients protected from any of the problems associated with thrombolysis. So the nuts and bolts, as I would call it, the basic three components of how should one do it, I would call it a certain building blocks of thrombolysis. Knowing the rules is extremely important. Now, without the rules, you cannot play the game. And number third is collaboration. Now, these three basic principles, I believe, play the background of how to carry out a thrombolysis without major problems. So what are the building blocks? The first thing that you see is a team, and that's what I see as a building block. And what is your team? A team is a stroke team. So looking at the stroke team, there's nothing you don't need to really run around, get many people from across the board or across the city. They're right there in your hospitals. So make sure you get your team together. If you don't have a neurologist in your hospital, and that's exactly what is happening currently across a lot of systems, and we are training emergency medical physicians. The physician, a neurologist if available, a radiologist is important, and maybe a cardiologist or a neurosurgeon, and a stroke nurse. Now, these become the most essential components of a stroke team. Get them together so that you're all on the same page, discuss your plan, and there you are all set to start up a stroke program. the machines which are needed, the tool kit, the number 2, or the stroke kit or the stroke box. Why that is important? Because over the time, as you start, you realize that you need things in hand, and we need to do things quickly. That everybody knows. You cannot afford to waste time. So get your tool kit, the stroke box or the clot box, whatever you want to call it. And there are right now, there are NGOs or organizations which provide you with the stroke kit, ready-made stroke kit, which has paper written protocols, which you can put the different investigative tools like the glucometer or the INR point of care, etc. So we should have it ready at hand so you do not waste time. And a machine, which is the most important, I would say, backup or most important requirement of a stroke thrombolysis, a 24/7 working CT machine. So you have the building blocks ready. What do you do there? So knowing the rules is important factor as far as the intellectual discussed. So knowing the rules, primarily, the rules are created by, simple rules are available in form of guidelines. So I would suggest everyone to update yourself. Keep yourself updated with the new changes because things keep changing. However, in stroke management, things change at a very slow pace. From the time it started in 1999, the guidelines were very slow to progress, but in the last few years, especially 2016, there has been a drastic change in our guidelines. We all know that there's a complete paradigm shift with endovascular treatments coming into the foray. So looking at the rules, one of the 3 most important aspects that I would divide the knowledge about the rules is about imaging and investigations. Which imaging is best for you and what kind of investigations do you really need before you go ahead with the thrombolysis? How do you select the correct patient? So I would try to cover most of the things. It's not possible to cover all the permutations, all the possibilities in a thrombolysis, and also know the exceptions. Because if you don't know the exceptions, there's no point of knowing the rules, because rules sometimes may not provide you everything, and sometimes you need to bend the rules too. But like I say, we should not be we should not be over courageous, not be cowboys, and sticking to the rules within the constraint of the rules is the safest bet that you can think of. So what are guidelines? Like I said, know the guidelines. Guidelines have, in recent times, for thrombolysis, we've had recent updates, especially the certain previously known contraindications or the informations for thrombolysis, they have got slightly modified, and we've become more liberal in the use of thrombolysis right now. So guidelines are not a commandment, remember that. So something which comes in a guideline has been accrued from loads of literature, and they become a source of information and something which is a roadmap, as we call it. So don't understand that it's a commandment. That is the reason, that is the only way you can bend the rules, because you know the guidelines, but without knowing the guidelines, you should not bend the rules, because that would be like blindly falling into the sea. There is a class of recommendation in most guidelines and a level of evidence. So I won't go into details, but in general, if we have class 1 recommendations, they are the strongest recommendation, which usually indicate the benefit exceeds a long way from the risk. And there is clear-cut indication based upon the level of evidence, which is number of RCTs. And one is very safe to go ahead and use that recommendation for your treatments and thrombolysis. And it would work in most of the patients and in most circumstances. As we go down from class 1 to class 2, the recommendation kind of gets weaker, and class 3 are usually harms. So do not touch recommendations of class 3. As a class 3 recommendation, whatever is mentioned, please stick to that, because otherwise you're surely going to fall into trouble. So the imaging and investigations. Now, imaging becomes the biggest requirement, and without having a recourse to imaging or the availability of a 24 scan, you would not be able to go ahead with a proper or appropriate thrombolysis. So what is the imaging? In imaging, Traditionally, there have been, of course, the CT scan is still and was always the most widely available investigation, still remains. And the biggest use that we use a CT scan is to rule out a bleed. Then there are signs of early infarction. And if we remember in the early years of our stroke knowledge, there was a lot of importance given to signs of early infarction. I'm sorry, this slide, I think the animation got skipped. So there were signs of early infarction like dense MCA sign, insular ribbon sign, lenticular loss of the lenticular hyperintensity, etc., etc. Now, what is the importance of knowing these? I will just talk about that. Remember, the CT versus the MRI. CT is more widely available. So whenever the controversy arises, whenever you are setting up your protocols, someone might say, let's use an MRI. Someone who's got a very easy access to MRI. Now, certain things need to be remembered. MRI in most hospitals would not work 24/7. There'll be a rest period for the MRI. Number two, you may not be able to get your patient wheeled directly into an MRI, because if there's a patient ongoing with an MRI, there's going to be a big delay. So stick to a CT scan. A single, simple, non-contrast CT is more than sufficient to give you adequate information to decide upon the right patient for your thrombolysis. So as of now, I can tell you, let's not be bothered about the signs of early infarction. There was a lot of time wasted personally, and I believe even in discussions, even on rounds, a lot of people come to signs of early infarction. So in terms of rapidity of treatment in the acute stroke, let's just forget about the signs, and I'll tell you why. Something more objective is important. Now, first thing is, signs of early infarction are more subjective. Some people see them, some don't see them. So that's one thing. And the second part is, there is not enough evidence which tells us that those early signs of hypoattenuation at different aspects of the brain really tell us about the extent of damage or extent of ischemia in the brain. And those have been now kind of avoided. Now, they have been recommended that we do not need to seek or see the signs of infarction. Aspects is an objective way of looking at slight changes in the brain parenchyma in terms of hypoattenuation. And what it does is, again, doesn't tell you that you get there, that you do or do not do. It just tells you a certain risk. And even aspects has been in the guidelines. It may say that do not rely on aspects to take the eligibility, but that just tells you the risk of probably having a hemorrhage. So aspects is a 10-point score, and you exclude 1 point for involvement of different areas like the caudate, the lentiform nucleus, the insula, the 3 M1, 2, 3. This is a ganglionic and a supraganglionic levels. So there are two cuts that you see. So importantly, like I mentioned, as per the most recent guidelines of the AHA, a CT is most recommended, and this is even guideline. And the reason MRI should be avoided is the guideline simply states that you should be able to get imaging within 20 minutes of arrival in the ED. I think that would be practically impossible if you take recourse to MRI, even if you do the shortest protocols with the MRI. So things to ignore, like I mentioned. So if you are really very concerned about dense MCA, you look at it, stay happy, don't further bother about it. One is the dense MCA sign is not 100% accurate. Many times you have false positive dense MCA signs. Second are the early CD signs, which I just said. One needs to just look at them for academic purposes, but don't let them interfere in your thought process in the acute stage of the stroke. Aspects less than 7 possibly indicates an increased hemorrhagic risk. Just know about that. And clearly, like I mentioned to you, the guidelines clearly mention a class 3 recommendation that there is insufficient evidence to identify threshold of CT hyperattenuation severity, how that affects the response to TPA. So simply stated, let's not really at that point of time, you want to have academic discussions, please do that later once the patient is thrombolized and shifted to the ward. The same for the CD MCA. Do not use that as a criteria to hold back IVTPA. I've experienced a lot of times from various aspects of our team and various corners, nooks and corners, the discussion coming in, oh, there's a dense MCS sign, should we go ahead? So rather than having any kind of confabulation regarding these sorts, these major things should be avoided. What about an MRI? How good is an MRI, or what's the advantage? The biggest advantage of an MRI is, apart from the disadvantages that I just elaborated, you can look at acute parenchymal changes. The diffusion weighted imaging is highly sensitive in picking up acute changes, which may get missed on a CT scan. The best advantage that we have currently, as per the recent studies and also certain pointers in the guidelines, that you may use the diffusion weighted and flare match in patient last unknown best seen time. If they wake, for example, in a wake up stroke, when the best last well known time is unknown. However, remember that diffusion weighted imaging may show false positivity in certain conditions, like seizures and encephalitis, etc. Second extreme is you may use diffusion negative, acute diffusion negative situation. This is one of the patients which I'll elaborate later on for other reasons, where you may get a CT normal as well as a diffusion weighted imaging completely normal in these patients. Later on, you may get these changes elaborated on a later date. This is quite common, especially in posterior circulation strokes, as well as inflammation for us. So if going across this and crossing this threshold of the controversy between CT and MRI, the score of CT is clearly, it overrules the use of MRI, at least in the acute setting. Definitely, MRI gives you great information of the parenchyma, but at that point of time, we can get sufficient information from a CT which can be derived from sim CT and not even more CT to stick to the rules of thrombolysis within the first 4.5 hours. Even the recommendation, the ISO 2021, it's only used for patients who are presenting beyond 4.5 hours. Otherwise, CT is very adequate. So what are the investigations which are must out of the whole list of investigations? If you look into the exclusions or the way of thrombolysis, there are certain which you may avoid. The ones which are with the red buttons: creatinine, platelet count, and INR. Now, there's always been, again, a huge controversy around these investigations in the acute setup. Should we for the platelet count? Should we wait for the INR? Now, INRs become easy since we have point of care machines right now, and platelet counts may be sent, but we don't need to wait for the report. And same for serum creatinine if you're especially having your protocol of CT angiogram. So do not wait for these reports unless there is established renal failure. And only the assessment of glucose and ECG may be done if available. And glucose is important, and that's easy because everyone has a. So it's a constraint. Let's look at the next parameter which might make you stop. And there's always this, again, these are practical situations we face. A resident who calls up and says there's an 80, 85 or 80-year-old person. What do? We really need to thrombolyze. I think it's pretty unsafe. So let me assure you that age is no longer a constraint in the treatment of thrombolysis. There have been ample trials, mainly IST3 and ECAS3, which enroll patients. IST3 clearly, although it was not a negative clinical trial, showed that patients over age 80, it was safe to thrombolyze. There is ample data to now suggest that age is no longer a contraindication. And with now clearly guidelines, the guidelines clearly state that for below 4.5 hours, people over 80 years of age, high quality of evidence. So do not please stop at the age of the patient. So selecting the right patient, that would be the second step in this part of the carrying out the thrombolysis properly. Well, who's the right patient? Ideal patient. Someone who has come to the emergency, reaches right after 15 minutes of the symptoms. He reaches the ER in 10, 15 minutes. He's happy. I mean to say, not happy in terms of his disease, but he's happy to talk to you. He listens to you, and he doesn't waste time to take the decision. He's eager, consents very easy to TPA, and clearly has no exclusions to IVD as per the license. However, in reality, things are really different, and we may not get such patients. It's very difficult, as all of my colleagues would definitely have experienced, especially even in India, since the time the rights of patients have been declared primal here. So the biggest challenge we face is first to convince the patient in quite a good number of cases, and also taking their consent. So one has to develop a skill and an art to tell the right information. I'm not encouraging you to give the wrong information. Give the right information, put the right perspective, tell the patient how safe or what harms TPA or the thrombolytic agent can do, and what are the benefits accrued. So that's one area which comes with experience, and most people can. So even look at the IPTP recommendations. Since the time the guidelines came in the early 1990s and then 2000s, few of the things which are there in the early TPA recommendations are changing. So some of them I'll point out here. The most important ones, the controversial areas where there are a lot of questions arise. So you have a patient in whom the deficits are minor, something like a minor facial palsy or a mild drift of the arm. And there's always, again, a big question arising in the emergency and a lot of concern. Do we really need to treat this patient? We might harm the patient. We leave the patient, he gets okay. So minor signs, spontaneously clearing, minor strokes, deficits which are clearing. And on the contrary, the other end, very severe strokes. So very high NHSS strokes. So these were all in the exclusions earlier. So what is the current status? Also MI in the last 3 months. And another important factor, which I'll take discuss first, is the appearance of more than 1/3 density. We have been talking of this since the time of NINDS. It was a major exclusion in the NINDS trial to exclude patients with 1/3 hypodensity of the hemisphere, likely indicating a large area involvement and a high risk of hemorrhage. Now, as of the current era, we still don't have enough evidence to state that the CT can really detect a high degree of damage to the parenchyma just on the basis of looking at 1/3 territory. So the threshold of hypoattenuation severity or extent that affects treatment response has still now not been proven, and it's been shown with multiple studies that even if you had hypoattenuations, not clearly infarction, but large areas of hypoattenuation, the treatment response was not bad, and there was no association of the treatment response with the TPA in relation to the area of the hypoattenuation. So there may be a poor prognosis, and however, but one may not preclude all these patients just on the basis that you thought 1/3 area of hypotension. However, if you see clear-cut infarction, which is not a hypoattenuation, there's clear-cut injury which is seen on the brain. That one has to be careful, and there in that state you have to hold yourself back and not thrombolize. So one has to distinguish hypodensity from hypoattenuation. Other areas, of course, which have changed over the time, there was initial INR of 1.5 and 1.7. The most important thing, what I would suggest is have written protocols in the emergency, like the one, for example, we use in the emergency. All the exclusions are written in the same form. We record all the data of the patient. That is usually helpful because at that point of time, the resident may not have enough time to rethink and think, although there are apps currently available which they can take recourse to apprise themselves of the recent exclusions. So looking at the license, again, now the exclusions have been different countries. So like I said, another area of major controversy is minor deficits, so strokes and minor strokes. So for severe strokes, again, these are the strokes which we call higher NHSS or seemingly chances of high chance of a hemorrhagic transformation. Now, initially, they were also excluded in the NINDS trial, as well as in the early guidelines, we were supposed to exercise caution. But studies over the time, as well as the initial subgroup analysis of the NINDS trial, did show us that the patients, even in the severer category of the strokes of greater than 20 NHSS, their benefit was definitely better if they were treated with TPA rather than not being treated. So currently, we don't need to withhold back TPA or strokes or thrombolysis in strokes with severe symptoms or high NHSS. Although there's a high risk of hemorrhagic transformation, there is definitely a benefit which gets accrued even with severe stroke symptoms. So what about minor improving strokes? Now this patient, which I've been showing quite often, is one of the best examples I can show. A 60-year-old male who presents to us with within 40 minutes with an initial CT of normal. Right after we take him out of the CT, he starts recovering to NHS of 4. Fortunately, at that time, we had access to angiography. This is quite far back in time I'm talking of. And we got a large vessel occlusion in this patient, and we took a decision to thrombolize, which of course, and a perfusion which was done. Things were not clear in those points of time. So we thrombolized with full recanalization and excellent outcomes in this patient. However, things for quite a long time, even till now, till recently, were not clear. How do we approach a patient of recovering symptoms? So patients who do go on to have some recovery of symptoms, one has to look into the degree of deficit still left. So if there is a moderate impairment and patient in your understanding may be potentially disabled if that deficit was there, do not withhold the thrombolysis. So minor strokes and rapidly recovering strokes, one needs to know the definition. And there have been certain definitions of improving stroke. So if can
you please wrap up, almost getting over time.
Yeah. So if we need to know about disabling strokes, and they may include aphasias, which may actually score very low on the NHSS, hemianopia, visual sensory extinction, or any deficits that lead to a total of NHS. So even if the patient is improving but has not come down to 0, look at the kind of deficits. And for mild and disabling strokes, now it is recommended as per guidelines that we should not withhold, and there is clear-cut indication to even give these patients benefit of thrombolysis. Similar for milder strokes and lacunar strokes, clear-cut benefits have been seen in the guidelines, and even from registry data from the SITs, meta-analysis shows clear-cut benefits of lacunar, which are minor strokes. Recurrent strokes, again, this was a clear-cut exclusion in the guideline. However, if we look into the data, there is ample data which suggests that if the strokes, if you do happen to thrombolize within 3 months of a previous stroke, you may not have significant SICH. But again, here is where the discretion of the physician is warranted, and one has to look at the type of stroke. So what I would suggest, if there's a minor stroke in the past 3 months and it's a small lacune, you may go ahead and thrombolize. And although FDA has removed the recurrent stroke from its label, however, the guidelines or the AHA guidelines still states that if you've had a prior stroke in 3 months, it may be harmful. So here is the discretion of the physician, treating physician. As far as stroke mimics are concerned, there's ample data for us to suggest that do not waste time in looking for the possible diagnosis. Go ahead and treat it, because risk of SICH is very low in mimics, and they're considered safe to treat mimics. In the current time, again, NOACs, you may be faced with a situation where a patient had been taking NOACs. Currently, we just need to look at, you may not have all the access to thrombin time or ECG to measure the anticoagulant effect. So just look at the recent guidelines tell us that we can look at the prothrombin time for anti-10A and APTD for the antithrombin agents. And they can give us a indication of a clinically relevant anticoagulant effect of these drugs. So overarching effect, or the overarching rules are treat it early, because time is brain, we all know that. And this rule still sticks. Come what may, however rules may change, however indications may change, remember that we need to be quick. Our team has to be practiced to go very quick. And because the more time it gets elapsed, the odds of improvement, they keep going down. That we know that clearly. And this chart, everyone is all aware of. It's like the background of all thrombolysis, that the odds of improvement keep coming down, and the chances of hemorrhage, they keep going up as you delay the thrombolysis. And we should know the rules. As per rules, right now, the agent to be used, we can use TPA as clearly indicated up to 4.5 hours. Tenecteplase is now looking into use Tenecteplase, and in India, although it's approved, but please use the right dose and look at the clinical data. And know the times. There are certain recommended times that you have to stick to once a patient comes to the emergency. Although these are the classical door to needle times of 60 minutes, I would now, most hospitals are reaching close to 45 minutes because of the current times when we have been thrombolizing since years, and systems of care have improved to a level where rapid door to needle now, rapid treatment times are a norm right now in most hospitals. So current, I would call it 45 minutes would be your target in your emergency as a patient arrives. Certain exceptions, like I mentioned, is this patient, which I did show the scan earlier. This was seen recently by us with a 67-year-old diabetic hypertensive who came with unresponsiveness with some reduced movements. NHSS was 22, rest everything, parameters were normal. So now this patient, there was a high suspicion of a mimic because of the unresponsiveness and the normal CD at admission. So a MRI happened to be done 2.5 hours. Again, this was done in the emergency because the resident felt it's a mimic and he or she wanted to get an MRI for her own benefit, for her own understanding. The MR turned out to be negative. Although the patient was thrombolized, the MR was negative at the early day one. And so there was clearly a thought that this looks like a mimic. However, looking at the signs, it was suggested that there was something going on. So day 3, the patient started showing some signs of brainstem involvement, double vision, and left third node palsy. And we did MRI on day 5, clearly showed an infarct in bilateral thalamus and the midbrain, which was indicative of arterioporphyrin stroke. And the patient improved remarkably with the MRS of 1 at 3 months. Now, this fact of knowing that the MRI may be negative is important to consider, especially in posterior circulation, small strokes or lacunes, or even other posterior circulation strokes, where commonly the diffusion weighted may be negative even in the early period. One needs to remember that. So MRI is not sacrosanct in identifying all kinds of stroke. So the take-home tips, that's the last slide. Although I have a low threshold to thrombolize, that's what I believe in. You should look at every patient as a potential patient to thrombolize because, and even a mimic if you think it is a mimic, because leaving patient untreated, you are condemning him to a severe deficit and lifelong rehabilitation. Remember that. But stick to the rules. Within the constraint of the rules, go ahead and thrombolize the patient. Always follow the rules and be extremely cautious. Also to the exceptions, which I showed some of them. Do not play a cowboy and don't be over brave, because after the first few thrombolysis, there is a tendency to be very confident. And that's when we land into trouble. So don't land into trouble. Always keep the guidelines at the back of your mind. If you have a doubt, talk to your colleagues. Always confer with your colleagues. Maybe you have to call a colleague across the country, across the world. Do that. So this has happened with me so many times. We've had discussions transatlantic or even within the country for an acute stroke patient with colleagues. And do not ever forget post-thrombolysis care and monitoring, which I didn't take up because of constraints of time. That is one thing which saves the patient. You leave the patient after thrombolysis unmonitored, you're surely going to land into trouble. Thank you.
Thank you very much, Dheeraj. There's always something to learn, something new to learn from your talk. That was great. And now we don't have time for questions. We have a couple of questions which have already been answered in the chat box. What I request the speakers is that if they finish their talk within 20 minutes or 22, 23 minutes, then there will be some time left for interaction. But Dheeraj, that was just wonderful. Thank you so much. With that, I request...
the talk is for 20 minutes and we have kept specifically 10 minutes for student interaction because they would like to ask questions. So I would request 20 to 22 minutes maximum, sir.
That's fine. That's fine. That's fine. So Dr. Vijay Sharma, may I